Hello and good evening, good afternoon, good morning to everyone wherever you are in the world. And today I have a very important and interesting discussion about a document that has recently been created in the United Kingdom called the Perseus Report. And as soon as I saw it, I knew it was important. And I reached out to a few connections with regards to getting someone to speak about it. And I've had the tremendous pleasure to get one of the authors with me, and he'll be able to explain a little bit more about what was being done, why they did what they did, and why this could be relevant, not just for the United Kingdom, but for countries across the world. What should you be doing with this kind of information? Are these the questions that you should be asking of your officials? And critically, the report was meant to be evidence based. And so, therefore, it's less about who or what, but what it says in it. And so, there will be a link in the description that points to it. But let's get Nick with us to be able to explain a little bit more about what it was that they were doing at the time. Hi, Nick. Could I ask you to do a quick introduction of yourself?
Yeah, hi Philip, and hello everyone. I'm Nick Hunt. I'm a retired senior civil servant, and I used to work in the Ministry of Defence in the UK. I'm a professional engineer by training, and in the sort of second half of my career, I was responsible for the safety and effectiveness of ammunition, a whole range of munitions used by the UK Armed Forces, the Army, Navy, and Air Force.
Excellent. And one of the interesting things about you, Nick, is that your dad was a pathologist. Is that about right?
Yeah, he was a neuropathologist in Southampton at the General Hospital.
Excellent. And one of the reasons why I highlighted that is because I've recently been doing a presentation on the fact that autopsies, the first published autopsy, I did this just recently, was only done just about a few months ago, on somebody who died after being vaccinated. I find that unbelievable in the context of a system where pathology is the foundation of Western medicine. But that's just as an interesting point because of your father's background with pathology.
Yeah, he used to take me when I was a kid. He used to take me into his lab and show me brain samples and all sorts. So I grew up not squeamish about that sort of thing. But on autopsies, I think your comment might be just about the UK. They've been doing them in other countries.
No, well, I say that usually people need to differentiate between autopsies being done, because autopsies are done all the time by the coroners. But in terms of published autopsies on
Okay.
research, when you are looking at what were the outcomes of the impact of vaccination on people who died, looking at different organs specifically to understand it, only the first one was published a few months ago, which to me is unbelievable after
Yeah,
13 billion doses. So
I agree.
that's the connection. So
Mm.
let's get into some of the questions here. Can you explain to us what really is the Perseus report in the context of, who puts this together and why? What is it about?
Probably need to wind back about 18 months, 2 years,
Mhm.
to understand where the people who contributed to the report, where they're coming from. And if I talk to myself, to my own motivations first, my background in safety of munitions and effectiveness, I know how long it takes to develop and prove the safety and effectiveness of them. And for a simple one, like just a small bullet, it would take at least a year from a production standard. For a complicated system like a missile or a torpedo, it would take 3, 5, even more years. So when they were talking in the UK about licensing the COVID vaccines after about 9 months. I thought that was incredible in the truest sense of the word. And so I started using my knowledge of safety management to ask questions of the MHRA in the UK. And I didn't like the answers I was getting. One of my first questions was, can I have a copy of your last safety audit? And safety audit reports would tell me a lot about the intricacies of what their processes are for managing safety and how good they were at doing it. And they hadn't been safety audited. They managed to produce a quality audit of half of their activity, the in-use monitoring of medicines, not even about the licensing of medicines. And it's not worth going into it here, but the difference between a safety audit and a quality audit are enormous. So it got me even more worried. I asked more FOIs. The more I got answers, eventually, the less I liked what they were doing. And I can't remember exactly when it was. It probably was middle of 22. I started writing articles in the Daily Skeptic about these shortcomings in their safety management. And someone picked up on the articles and put me in touch with someone else who had concerns and so on. And we ended up in a group which we only latterly called ourselves the Perseus Group. The other people in the group, some of them are medical. They'll have been concerned, I know, about the way, not only the way they licensed the vaccines so quickly, but the way they rolled them out down the younger age groups. Less acceptable.
I wanted to pick on something that you said there, Nick, because I'm very interested in something you just said, which is that when you started writing about your concerns, you did it under a pseudonym.
I did.
Why did you do that?
Well, at that time, there was still a lot of pro-vaccine lobby and, shouting down anti-vaxxers, and I didn't need all that. I just wanted to get the message across. I think the messages need to stand on their own without people being attacked personally. I'm over that now, and that's why I'm sat here talking to you.
Yes, but it raises a question, and before we even go into the Perseus Report, because I suspect that there will be many people like yourself who have concerns. So here's the bit that I find very interesting. If you were still working in the Ministry of Defense, okay, and you're still active in your job, how would you feel about speaking about these concerns?
I think the difference would be that I wouldn't be sat here talking to you about them if I was still employed. I would have almost certainly written the articles that I wrote under a pseudonym. I would have still contributed to the report and helped with all the other aspects of that, but I would have had to retain my anonymity, I think. But one thing I might have done is actually try and do something behind the scenes, within the MOD, and talk to the MHRA, within official channels, because it isn't that their approach to safety management is a million miles away from what I was used to. And I want to A, know why, and B, help them do it better.
Yeah, no, these are big questions. And I think the reason why I touched on that before I went into the report was because I think people underestimate how many people there are like yourself who just sometimes need someone to stand up and say something. and to ask the hard questions, the questions that are not easy to ask, but then suddenly when it is asked are very, very reasonable. And the reason I'm picking on this, because there may be people who are watching this, who are still employed, who are very afraid of rocking the boat because of the risk to their jobs or to whatever else is going on. What do they do? Do they just stay quiet because of those concerns?
No, well, I don't. Just speaking for myself, I wouldn't have stayed silent. I would have just retained or tried to retain anonymity. There are some brave people who've stood up and gone public, in employment. And the trouble is that they do get vilified,
Yes.
and their careers harmed. We don't need to name. We all know who they are in the UK.
Yes.
Very brave people.
Yeah. So it brings us then back to one important part about the actual document itself, and it's part of what you had said with regards to the authorship of it. An interesting thing that I found, and I'll just bring it up here, and this is the Perseus Report itself. And the authors, it's a multidisciplinary team of experts from various fields, including medicine, safety management, and pharmaceutical regulation. You didn't put the names. And the question is, why didn't they put the names?
We want the report to stand on its own merits. It doesn't offer opinions or anything like that. It's based on factual evidence that has been gathered and collated from a whole range of sources, like freedom of information requests and other communication with the MHRA. And the first thing that would happen if we put our names to it, all of us, is that they would have been attacked personally in an attempt to undermine the report. Well, if we don't stick our names on it, then it's harder they have to challenge the content of the report. Now, I'm relatively speaking a nobody. I've got no track record in doing this sort of thing. I've got credentials in safety management, which I've applied to what's written in the report.
Mm-hmm.
That's why I'm sitting here, but we haven't named the authors in the report.
Excellent. Yeah, so that's a valid point, because I suspect that there would be people who would question from that point. And I think it really brings to question one of the interesting parts of the pandemic is that there has been this talk about who is an expert in the COVID-19 pandemic. We're now 3 years down the line, and we've had the people who should be the experts should be leading the way, and we are not out of the pandemic. Are they still the experts?
Well, I'd probably answer that from another direction. Suppose not everything in the report is 100% correct. We're confident it is, but suppose somebody thinks it isn't. But at the very least, it's generated, and they are listed in the report and on the website, perseus.org.uk, a whole list of questions that really parliamentarians, policymakers, and the media ought to be asking. There's enough weight of evidence there to ring alarm bells. We're very confident in, and that's why we've gone to the lengths of sending it to all MPs and Lords, peers in the UK, and to key figures who you've referred to as experts. June Rain, the head of the MHRA, and other experts who've had something to do with the rollout of the COVID vaccine. We're confident in its contents and the questions that arise from it, which should be asked.
And so you think the questions are big enough at the moment that they should actually suspend the vaccine rollout or the use of it until they have clarified it? Or would you say that the pandemic and the risk to lives from the infection supersede?
No, I think stronger than what you've just said. I think I don't think it's a question of pausing and clarifying. I think there's a fundamental problem with the safety management of these vaccines. It's not just what I think; it's what the report concludes. It needs a proper inquiry into MHRA's regulation and safety management, not just the COVID vaccines, incidentally. Everything. I mean, there's a section in the report on best practice safety management, which MHRA don't follow, which applies to their regulation of all medicines. I personally have lost complete faith in the safety of all medicines.
Wow.
And to put it bluntly, if they haven't been in use for let's say 5 years, I'd be really wary. And if it wasn't a life-saving situation, I would, you know.
Wow. So those are big statements in
Yeah.
relation to the actual standards. And this is, you're talking about the Medicines Health and Regulatory Agency in the UK.
Mm-hmm.
But do you think that this applies to the regulatory agencies in each country? Because every country has their own regulatory agency.
I know, and they all have different degrees of influence, I think. I suspect. I haven't looked, to be honest, I haven't looked too much at the other regulators, but from what I have looked at, there are some leaders, so the MHRA, the US equivalent, which I think is the CDC.
Mm-hmm.
No, sorry, the FDA.
FDA. Mm-hmm.
And some of the Scandinavian ones are, in the Premier League of regulators, other European ones, and then other ones around the world. But, other countries have less mature national regulators than those.
Mm-hmm.
But as far as the Premier League ones go, as far as I know, they all suffer from the same sorts of shortfalls.
So in relation to, you mentioned the Scandinavian country, and you raised the point, it's not Scandinavia, Switzerland, but Switzerland has just done, effectively, they have said in their recommendations, they are no longer recommending COVID vaccines, and
Yeah,
they will only give it if the doctor technically prescribes it and says that the person should have it, and somebody can get it, but they have to pay for it.
yeah.
So are we seeing the breakaway of different views? I'd recently done the question. The FDA is still recommending it. Switzerland is no longer recommending it. The UK had stopped the boosters and is now starting a spring booster. Who seems to be following what science?
It's not unreasonable, I suppose, for different countries to have different approaches because they've all got different perceptions of safety and risk and benefit. Back in my profession, different countries would use the same munition but under different limitations, depending on their tolerability of risk, and that may be part of the explanation. I mean, I think it's the case that in relation to the AstraZeneca COVID vaccine, the Scandinavian regulators were among the first to suspend its use. I think Austria also, maybe even Austria was the first, but they were far quicker, months quicker than the UK MHRA to act on the same evidence, because they all share the same safety evidence. They've got European adverse event report systems.
Yeah. And so when you actually think about that, when AstraZeneca was technically suspended, they never put it like that.
It's still licensed.
Yes. So therefore, why didn't that raise questions? It seemed as though they perceived that this was a pharmaceutical issue, so that it was due to the formulation of AstraZeneca, as opposed to probably, could it be that just vaccination in the context of COVID-19 was a risk in itself? with the spike protein. Why was that not thought of at that point?
I can't. I don't know the answer to that, but the issue for me is that it's back to your earlier question: why do different regulators take different approaches? In some countries, the AstraZeneca vaccine has been withdrawn, but in the UK, it's been inverted commas withdrawn, suspended inverted commas. Nothing formal has been done. It's still licensed for over 40s, I think, or under 40. Anyway, it's still got a license within the UK, even though the JCVI, and for people not in the UK, that's the separate body which decides once a vaccine has been licensed, which demographics get that vaccine at what time. So they were in charge of rolling out to different age groups, but it was they who decided not to give it to certain age groups, but it's still formally legally licensed
in the UK.
Which is ridiculous, utterly ridiculous.
Yeah. So I'm going to bring up a piece of the report that jumped out at me. And it was this bit here, when you guys put in total number of adverse events based on ultravigilance with common vaccines. And you showed here that 673 million vaccines, measles vaccines, were done. They almost had 49,000 adverse events. Polio, similarly amount, they had only about 9,000. All the influenza vaccines, we don't know the total number, but it will be quite a lot, only 44,000 adverse events. Compared to COVID-19, their vaccines, 1.8 million. And that's what we know so far.
Yeah. Now, the first thing is there's much more data like that. We got that from the World Council for Health Pharmacovigilance report, which is easy to find online. But I have to point out, as MHRA would be the first to, that an adverse event report doesn't equal causation. However, those figures are so alarming that you have to look harder, and they should look harder. And if I could just go into one of the things that astounded me early on, I asked MHRA for a copy of their process for investigating yellow card reports. And they wriggled and squirmed, and I had to ask for a review of their first answer, was they didn't have such a process, which absolutely astounded me, because if you work in the defense sector, the oil and gas sector, the nuclear sector, aviation, you name it, they'll have a process for investigating incidents, whether they're minor through to fatal. They'll have a process, and that's to make sure that everybody knows how to investigate them, what information is required. And yet the MHRA don't have such a process. I've spoken to people who've lost loved ones and submitted a yellow card report, and the MHRA have eventually, after about 3 or 4 chasing emails, contacted the deceased GP, and then it all goes cold. What about that person's health records? What about the other medication they were on, et cetera, et cetera? And then, someone else actually had asked them how many of the yellow cards reporting a potential link to a fatality from the COVID vaccines had been investigated, and the MHRA didn't know. They said it would cost too much to find out, which is, if you stop and think about it, absolutely staggering.
Well, this would therefore fit into the fact that it seems that no one is interested in trying to understand the patterns with excess deaths. It's almost as if this has just been accepted as a consequence of the fact that the vaccine rollout needed to happen. And so you're raising a question here that really got me thinking. the MHRA, based on what I've been reading, I can't verify this, but the majority of the funding of the MHRA is from the pharmaceutical industry. When you think about the regulation of munitions, say in your area of expertise, who does the funding for that? And do you think that has an impact?
I happen to think that the funding source is a slight red herring, a bit of a distraction, and I'll explain why. So MHRA, companies wanting their pharmaceutical products licensed pay a fee to the MHRA. Companies producing medical devices, they mostly don't pay a fee to the MHRA. The MHRA fund it from, well, it's basically taxpayer funded. The government votes the money to the Department of Health and gives it to MHRA. So it's free to the medical device manufacturers. In my world, in defense, it was the same. We would decide what we wanted to buy, and we would basically pay the costs of licensing whatever it was that we were then going to buy and give to the armed forces. I think what I've asked myself is, suppose it was the other way around with medicines and the Department of Health paid for the cost of licensing the pharmaceuticals products. Not only do I think the criticism would come, why is the taxpayer funding the pharmaceuticals to license their products? That's ridiculous. The taxpayer shouldn't help the pharmaceuticals make profit. And the other one is, I don't think that regardless of the way around the funding is, it would make much of a difference because of the failings in their safety management.
And
I
so
think it's a bit of a red herring.
yes, I understand that. So then how do you explain what it is that you, through your digging, and just explain to people what freedom of information is, because many people would have heard you say FOI and so on.
Yeah.
What exactly is that, and how does that relate to the answers that you've been getting that many other people don't know?
Yeah, so many countries have something called the same or called different, but the same principle. The Freedom of Information Act of 2000 in the UK allows anyone to ask a question of an official body, and an official body can range from a government department through to a hospital trust, for example, to use your area. And there are, other, below government department, like councils. You can ask a freedom of information request to a council, but you can't ask them a question like, why do you do this? Why do you do that? You have to ask for a copy of this. Tell me how many of these, etc.
And so, yeah, because it explains so that people understand that this information that you were getting wouldn't be in the public domain, but it is because of your specific expertise with regards to understanding regulations and quality control that you knew exactly what to ask. And so, therefore, it is out of that knowledge that you are bringing to our awareness, because, as you said, the question of the yellow card system, it is shocking that it is there, but nobody looks at it. So then what is it there for?
Well, yes, it's my knowledge and some digging around that I did to find out what I thought were holes in what MHRA were doing. And of course, there's many other people with expertise in different areas, like you just mentioned, manufacturing and so on, who are asking very detailed questions about the, down to what's the water content in the COVID vaccine, what's the quality audit trail for this particular ingredient within the vaccine. And at least one of the ingredients, something to do with the lipid nanoparticles, didn't have any quality track record at all. It had never been used in a human application before. And yet this was something that was approved within 9 months of them starting. Well, assuming they started when the pandemic started.
Right. That's a different question.
We've avoided getting into conspiracies and
Yes.
opinions like that.
But it raises even a critical point, because I got here in your report here, and you have pointed out with regards to miscarriages and spontaneous abortions, never before has the MHRA authorized the use of a medicinal product to the pregnant population with such a paucity of data, including no long-term safety data. I think people will struggle to believe that this is accurate, and they would think to themselves that I can't believe that's true. That must be misinformation. Is this true?
No, it's absolutely correct. I mean, by definition, they cannot have had any long-term safety data after 9 months. It's impossible. And I can't remember the event she said it at, but June Rain, it might have been at the House of Commons Health Select Committee. I heard her say something about, we've never done that. We don't test things on pregnant. Sorry, we don't. Yeah, we don't test things on pregnant women. Something like that. I'd have to dig up the reference, but I'm 100% confident that statement is true.
Yes, and these are, and I don't know. That one of the big concerns I've always had, even though I think it is important for us to raise questions, I worry that we cannot afford to destroy the credibility of an organization that we depend on in terms of other things. So it's not just about COVID-19 and COVID vaccines, but we depend on the MHRA for multiple other drugs and procedures and devices that are coming through the system. Should we just accept that maybe there were some errors here, and they will learn from it and we just move on?
Absolutely not. No, this is for me, it's structural and fundamental. They just don't do the basics. They're not. They don't have the organization or the culture to do safety management like it's done in other safety critical sectors. And I'll give you a couple of examples. One is, and that these examples are related. One is organizationally, they're split between the licensing of a pharmaceutical and the pharmacovigilance, the monitoring of it once it's in use. There are two directors, one for licensing and one for pharmacovigilance. You can't split accountability for safety like that. It's basically the guy who's licensing something then chucks it over the wall to the person who's monitoring it in service. It's got to be managed as a whole. That's how other sectors would do it. And another one is that, and it is related to this, in my world, I had a personal delegation from the Secretary of State for Defence, flowed down from him, not a letter direct from him, but flowed down to me, that told me what I was responsible for in terms of the range of things, products I was responsible for, and safety and effectiveness, and what the rules were that I had to follow. And I was only allowed to have that delegation once my competence had been assessed in terms of, experience, qualifications, training, and so on. The MHRA don't have that. The Secretary of State for Health is accountable for the safety and effectiveness of medicines. He lets the MHRA get on with it, but within the MHRA, when they license a medicine, a group of assessors look at all the evidence that is submitted by the pharmaceutical company and seem to make a group decision. They've put in writing that there is no one individual who takes the decision, they say, other than the Secretary of State. But I don't, that isn't what happens on a day-to-day basis. I worry about all medicines, and I know it's disappointing that the report is saying that in relation to the MHRA. You're right, they are supposed to protect the public, but we don't think they are.
And these are almost frightening to consider the implications of this. But I had spoken previously to somebody who'd worked in the pharmaceutical industry as a vaccine regulation, Susan, and she had mentioned something that has stuck in my head, and it seems that what you're saying here fits. No one is responsible and no one is accountable if something goes wrong. Is that about
Yeah,
accurate?
that's exactly what I'm saying. And if you want a bit more evidence, or it's going to be circumstantial evidence, but if you think about how long it takes for, from the point of, with a medicine that someone thinks there's a problem to the point it actually reaches a disaster and, there's a public inquiry. If you take the Cumberledge inquiry, I can't remember the timescales off the top of my head, but it's got to be 10 plus years between the products being licensed and them having to be stopped or severely limited. In the UK, that was a report that was published in 2021, I think, over an inquiry in 2019. But it highlighted the number of years over which it took for someone to actually take responsibility and say, no, that needs to be stopped. And the swine flu vaccine in the UK in 2009 was another example. It took 7 years, I think it was 2016, before it was debated in the House of Commons in terms of damages for people harmed by that vaccine.
So I like to do hindsight thinking, and I like to ask hard questions about what was happening. So the MHRA and people who have been pushing forward with the vaccination program would argue and say that at the time when we were developing vaccines to try and save lives, there wasn't time to do all of those assessments, and they had to just move on getting it out there. Okay. So, using your expertise in regulation, suppose you're in the middle of the war, you're running out of munition, you don't have the time to test and see, the soldiers just need weapons on the battlefield. What do you do?
Well, that happened a number of times. There would be a specific operation where there was a need for some new munition or an existing munition to be used in a new way. And it was possible to qualify that particular application very quickly based on very limited evidence, but only if there were strict limitations on its use. And I'll give you an example. When you carry something in a helicopter is a bad vibration environment, and vibration's bad for explosives. So you would only be allowed to fly that whatever it was for one flight, say, because you didn't have any data that would let you do any more than that. Whereas if you did a full-scale 5-year qualification program, you might be able to carry it for 1,000 hours in a helicopter, multiple flights. It's the same here in medicine and the COVID vaccines. I don't have a problem with them licensing something based on very limited data for very limited applications under strict limitations. And why on earth? They knew what the profile of age susceptibility to COVID was and how it rose or decreased exponentially the further down the age groups you went, so that under about 70, you weren't, I can't remember the exact figures, but you weren't at significant risk from COVID. You had to have comorbidities as well. Why on earth did they start rolling out to lower and lower age groups, still based on very limited data? I just don't get it at all.
This is a very important point and something that I think, as I said, I had always argued for targeted vaccination, which is that we knew the at-risk group, we knew it was
Mm.
comorbidities, we knew it was age, we knew it was obesity. You target the at-risk group. So, what were you thinking when you saw the rollout to the whole population? It started to go first. They did target it first, but then it's almost as if we've got enough vaccines. Let's just vaccinate everyone. How
Mm.
how how would that decision have been made in the context of the MOD?
It wouldn't, frankly, it because it goes back to partly what I was saying earlier, that I I was personally responsible to the Secretary of State for Defence. I mean, he could have overruled me, but I wouldn't have suggested it. And there was a separate regulator who would audit the decisions I made and made sure that they were sound. And I don't see how that decision to roll out to younger and younger age groups, given the evidence about the risk from COVID and the limited data from trials on the vaccines, could have justified that.
Give us an analogy in the context of the military. What would be the analogy for what happened with that rollout? So you didn't have enough time to test the munitions, and then what? You just decided to give it out and transport it no matter what with no regulations? Would that be the equivalent?
Um, I can think of two possible ones. They're not that good. I mean, it would be, in terms of what I had licensed
Hmm.
something for emergency use in a particular theatre. The soldiers on the ground would either have to stick to that, or, and there was a procedure where they could actually take responsibility themselves, take it off me and have it themselves. They could effectively do whatever they were able to justify through their operational command. Because I'm not there, I'm not under fire. They're the ones in the line of fire. They need to be able to make urgent decisions like that, and there was a procedure for doing it. The other one might, in terms of how do you extend the rollout based on limited data, well, I suppose you might be able to say, well, you've licensed it for this, therefore carrying it in a, I don't know, in a lorry or something might be no worse, even if we hadn't said it was okay. I don't know. We haven't got
Yeah.
as good an analogy as I think
Does
you.
it? So I tell you why that I was thinking about it, because the emergency use authorization was probably equivalent to what you said, where
Yeah,
the
absolutely.
soldier in the field could make the decision to do whatever he wanted, but it was his responsibility if there was a problem. Is that about accurate?
No, the temporary authorization, what you called emergency use, was the same as what I called they were called urgent operational requirements. We would approve those based on limited safety evidence. That's equivalent to a temporary authorization. What I'm saying is that in the field, in the theatre of operation, the military chain of command could take responsibility themselves. It would be a bit like, I suppose, MHRA giving it temporary authorization, and then you, a medic in a hospital, deciding that you're going to go outside of that.
Hmm. Yes, yes, yes. This is some very. I can't explain how worrying this must be for the general public, and this is why I said that at the same time, the government and the MHRA is probably worried that we're raising these questions for the general public to think about. Because is it one of those situations? And if you've worked in government, there must be some situations where you don't want the public to know.
You're asking someone from the Ministry of Defence.
And that this is what it sounds like, is that this is one of those situations where you don't actually want the public to think about it, and you try and see if you can get it sorted out as best as you can. Is that a fair assessment?
I can't think of any instance where I hid stuff. No. There are so many checks and balances that go on in the military. If we just, let's keep safety and effectiveness. I said I had an independent safety regulator, looking over my shoulder and auditing me, and so on and so forth. What I didn't say, but you've prompted me to do it, is the Army had their own regulator who would audit my team for the Army products that we were responsible for. And guess what? The Navy had a separate regulator who would come and audit. And guess what? So did the RAF. We were audited up the yin yang, which at the time is very frustrating and annoying because it's quite a distraction. But on the other hand, it does make you do the job properly, document it properly, have a good audit trail, and gives you confidence that what you're doing is safe. I don't see that with the MHRA.
I'll shift it to one of the questions that was raised. In number 5, you spoke about death. Deaths relying solely on death certification as a measure of the deaths used by vaccination could lead to circular logic. Additional methods of surveillance should be employed to accurately capture the true number of vaccine-related deaths. What exactly does that mean?
I think it was implying, I've got a copy here, it was implying that there was a bit of a culture of don't blame the COVID vaccine, don't link the COVID vaccine to the death. So you couldn't judge the number of deaths from the COVID vaccine by looking at death certificates, because certainly initially there weren't many that mentioned the COVID vaccine. There were a few.
And I think that from a practical clinical point of view, you almost have to be certain that it is the vaccine, where there is no other cause for the death before you would be able to put in that kind of certification. And the truth is that there are very few patients who have no comorbidities that would contribute to a death. And so therefore you can't be absolutely certain that it is related to it, and therefore you couldn't therefore do it. It's that kind of, as you said, circular discussion, which only can be addressed by big data. And the big data is looking at excess deaths and that kind of thing.
Yeah, you need both. You need as much evidence as you can get from the sort of individual level right up to the population level. And excess deaths is one example of population level data, but so is NHS data about admissions to ICU, outpatients, etc., etc. Cardiac arrest 999 calls, etc. How do they correlate with the rollout of the vaccine? How are they changing? And that's another observation in the report. The MHRA don't seem to be following through on that. They promised that would be a big part of their, they called it proactive vigilance in the UK, but a few questions and a bit of digging on the internet reveal they didn't follow that through, or did follow it through and aren't making it public.
And that was another question that was raised about the lack of transparency in terms of the MHRA. They've been slow to respond to the requests and often applied exemptions. What was that like from your own personal point of view?
Just annoying. It took them 8 months. People may not know this. In the UK, they are supposed to reply to an FOI request within 20 working days. If there is a body to whom you can complain if they don't, but they give them 40 working days, which is a month and maybe 2 months if you take into account this working days, not calendar days. It took them 8 months to reply to one of my FOIs, which was, tell me about the delegations from the Secretary of State down to the MHRA and to the people within the MHRA. They just 8 months. It's so frustrating.
Wow. And so, and when we come, I'm just coming towards the conclusion of the report. As you can say, I encourage people to read it for yourself because it is quite comprehensive. And as you said, look at the evidence rather than, it doesn't matter, just study the evidence and see if what they're saying is true. So one of the areas you highlighted in 16.2, the harm done to the vaccine injured and bereaved family members must be recognized. Is that a personal thing for you, or is that just part of the? What are your thoughts with that?
Well, of course, it's a personal aim of mine, but it's not what drove me to contribute to the report. There are others who have contributed who do know people who've been harmed, but my personal point of view is that we owe it to the people who have suffered as a result of this rollout to make good the harm that's been done. All credit to the likes of Christopher Chope and Andrew Bridgen and Esther McVeigh and the others who are involved in UK Parliament in trying to address that very point. And we're working, we're supported by those, the various groups that are representing those people and collecting signatures and are going to deliver them to Downing Street next Thursday.
Yes.
And so wait to get something done about this.
Is that the Together declaration, the open letter to the government?
Yeah, they're basically collecting signatures on our behalf, and yeah, we were working together with them on this.
I see. So this is for the UK, and you need how many numbers? You need 100,000 for this to go.
No, this is a petition that will be delivered to Downing Street. We just need as many as we possibly can. So anyone who's watching in the UK, please go on that website, and if you're as concerned as we think you should be, sign that open letter, and it will your name. You can actually be anonymous, but it will be delivered to Downing Street on Thursday. There is also a petition for a parliamentary debate about calling for an inquiry into MHRA's licensing of the COVID vaccines. So
and the purpose of that is to get the 100,000 signatures.
That's the 100,000. We need that to have the parliamentary debate. Yes.
And that forces it. And so as
I think we're up to about 30,000 now.
So you need 70,000 more for those who are listening.
So anyone who's watching.
And so as we come to the close, Nick, there are people, as I said, across the world who are listening to this. Imagine yourself in another country. What would you advise them to do? Because this needs to occur at national levels. There's no way to do this at an international level. It has to be done locally in every single country. What do they do?
I think all they can do in the short term is ask the questions of their national regulators, government, that we've highlighted. I think in the long term, this isn't going to be solved unless the regulators themselves change, or to some, this is a big part of it as well, the influence that the pharmaceutical industry has over the national regulators in terms of their, the influence they have. I'm not convinced that every medicine that pharmaceuticals sell to the NHS is actually much good at all. I've seen figures where probably a third of it's overall the risk is the same as the benefit. You might as well not bother with it. And it's that sort of thing which I think we need to get to as well, but that's another story.
That's another story. So, based on your experience, and this is now, I want you to give a solution. It's easy for us to criticize the failings of, say, the MHRA. And so let's pull back a second. And I'm now saying that, after today's conversation, the government reaches out to you and they say, listen, Nick, if we want you to implement a system that will make the MHRA as robust as it was in the Ministry of Defense, what would you then actually do?
Oh, I've thought about that. It's not that difficult in principle. It would be really difficult in practice to deliver it because it's a massive change. But I would do things like reorganize them so they're not functional stovepipes between licensing and pharmacovigilance. I would make sure that there was an individual responsible for the safety and effectiveness of an individual product or range of products, and that his boss would do routine safety management reviews of the products he delegated responsibility for. I would make sure they did safety audits. I would make sure they have enough manpower. We haven't covered that. It's mentioned in the report. I don't think they have enough manpower. I could go on. But at the end of the day, they also need a change of culture, and that sort of thing is hard to do. But in principle, the list of things to be done are, it's done in other sectors.
So it can be done in the health sector as well. That is a very, very reasonable point. And so when you think at your closing point to the general public, because your call is to the general public to read the report, it's also a call to the people in leadership positions. So is the call to the general public to put this information in front of their leadership so that they don't have the excuse of saying they didn't know?
Yeah, absolutely. The report has been sent to all MPs and peers in the UK Parliament. We would ask people in the UK to write to their constituency MP, email them, and say, here's a copy of the report. You've already got a copy. Have you read it? And what are you going to do? At the moment, most of them are remaining silent, even though I suspect many of them are aware, and they need to be shamed into doing something, not least, as you indicated, because they can't say they didn't know. The report's comprehensive. It draws all the evidence together.
Excellent, excellent. So thank you very, very much, Nick. I think this has really been appreciated. There are a lot of people here. There have been a lot of comments. I can't necessarily go to all of the comments that has been going through, but I'm hoping that this does what I would want it to do, which is to raise, one, awareness of the report so that people read it, and two, they take the next step of challenging their health authorities by putting this in front of the decision makers, not just in the UK, but I say that this report could be put in front of decision makers, whatever country it's in. And is it possible that this can be translated to other languages?
I did think about that, but there's so much technical language in there. And I know from my previous job that translating foreign technical reports into English is very time consuming, costly, and gets riddled with errors, and you have to be very careful. So in theory, yes. In practice, very difficult.
It probably just needs somebody with expertise to put it in there. The point being is that that's an action that everyone can participate in, putting the information in front of family, friends, decision makers, politicians. Make sure everyone reads it and has to come up with a conclusive rebuttal to the information, or else they should act on it. I think that's probably the lead, and that is probably what you hoped would occur from this report.
Yeah, I'd love it if my MP replied and said, well, I've read it, you're completely wrong, I'm not going to do anything about it, because at the moment he's just silent.
Yeah.
I won't
Thank
tell you who
you.
he is.
Yeah. Thank you again, Nick. I'll ask you to hang on with me just for a minute as I do this outro. And thank you, everyone, for watching with us. Look out for more presentations and look out for some of the Eventbrite presentations that I'm having. The next one coming up will be looking at a scientific, medical, pathological explanation for what could be the cause of some of these clots that embalmers are talking about. That should really be interesting. But otherwise, have a great evening to everyone and look out for more programs in the next week or so. Thank you.